Second half of the talk, I'm going to tell you the basics or rather the principles of management of malignant bone lesions, typically the extremity bone lesions. So most of this talk is going to be related to an extremity malignant primary bone in neoplasm. So think about all the slides from that point of view. And these are the cases which you are most likely to get in your exam. So all the slides in this talk are probably from a point of view of your exam case. So just a brief, primary bone and soft tissue sarcomas are extremely rare. They comprise only about 1% of all malignancies in the body, and more common in the patients that will present to us in a clinical scenario are metastatic cases of carcinomas, bone lymphomas, and in certain cases melanomas. So metastatic lesion is the most common one. What are the common lesions that we come across in the malignancies that we are going to concentrate on today? First one is going to be an osteogenic sarcoma. So that's the most likely case that you're going to have as a short case, mostly as a short case in your examination. The second one, the second and third places keep on changing, and they are divided between either chondrosarcoma or an Ewing sarcoma, which is also known as a CNET, or it's called as a primitive neuroectodermal tumor. So the middle part of the slide is what we are going to concentrate on today. Now, whenever you get a case of this sort in the exam, the approach is very much simple. I mean, it's the same approach that you would have for a hip case or for a knee case. So obviously, you are going to start with a proper history, do a clinical examination, think about the investigation that you are going to do. There are going to be a set of radiological investigations, and there's going to be a set of biochemical investigations or lab investigations that you are supposed to do. In the radiological examination investigations, you have a simple plain X-ray, a CT scan, plus or minus if required, an MRI scan of the involved bone, the entire length of the bone, and a staging investigation, something as the bone scan, or nowadays a PET scan. It will be beneficial if you know something about a PET CT scan as well. In the biochemical investigation, apart from the routine investigations that are done, two investigations are of importance as tumor markers or prognostic indicators. Serum alkaline phosphatase, that is the bone component, the bone fraction, that is going to be important from point of view of a bone forming tumor. What is that going to be? It's an osteosarcoma. So in an osteosarcoma and for any sarcoma, it's the serum LDH, lactate dehydrogenase levels. So these are the two markers that you're going to have specifically in mind when you speak about the investigations that are supposed to be done in these particular patients. Once you have gone through all these particular steps, you need to know something about the biopsy to establish the histopathological diagnosis, because you can't decide on the further course of treatment until you know the histopathological diagnosis. You can't treat the patient based on only the radiological diagnosis here. And then, after the biopsy diagnosis is available, the examiner is going to ask you, okay, now what am I going to do for this particular patient? So whatever case you may have in the exam, you need to think about what's going to be a rough plan of treatment. So in general, the examiner will want you to think in a particular fashion. They will try to understand your thinking. They will try to understand how much principles you have picked up during your training. They wouldn't be very much bothered about whether you can do a limb salvage surgery or not. Obviously, you are not expected to know about it, but they will like to know whether you have the overall general understanding about how do you approach an osteosarcoma case, how do you approach an Ewing sarcoma, how do you approach a chondrosarcoma, and what's going to be the follow-up protocol for these particular patients. Okay, so in the history part, typically the patient is going to present with two main common symptoms. One is pain and swelling in that particular affected extremity, and that's going to be of variable duration. Symptoms pertaining to pathological fractures like brevitas or abnormal mobility and sudden increase in pain are going to be extremely uncommon, and such type of cases won't be obviously kept as your exam case. What's going to be kept as your exam case is typically this kind of a situation where the patient is having a big mass in that distal femur, and he has one particular symptom that there is this mass. Well, I may have some pain occasionally, but I can't bend my knee completely. So that is going to be something, the case that you're going to be having in the exam. So typical complaint would be a range of movement restriction in the terminal area, mostly sometimes because of mechanical block. The joint movement may be restricted because of sympathetic effusion in the adjoining joint, or it could be just simple plain intra-articular extension of the disease inside the joint. So these are the different reasons that a patient may have joint movement restriction. So here's the patient. Suppose I give you the history that he is a 35 years old gentleman. He says that he's got some pain around his elbow, and he actually presented to me with a breast stroke. Okay, these are very rare scenarios for a tumor to patient. Since we are on a tumor talk, Obviously, this patient has got some neoplasia going around somewhere, and he had a wrist drop on the lower side. You can see that he's trying to extend his wrist, he cannot. He's trying to extend his thumb, he cannot. So what does that mean? That there's something going around, maybe in the elbow area, and we need to image him and see what is got. So he had basically a lytic destructive expansile lesion in the proximal radius, which was compressing on the posterior process nerve, leading to a nerve palsy. So very rare case scenario, but then this could be one of the presenting symptoms. Obviously, when we talk of inspection all the particular features that you need to know: the size, extent, dilated veins, neurovascular dystrophy, vesting, lymphadenopathy, anything obvious that you have to know. Confirm your findings on palpation. See what's the consistency of the mass. If it's bony hard, you may be thinking of a sclerotic osseous or an osteochondroma. If it is very soft, you may be having a very large soft tissue component of Ewing sarcoma. Or if it's somewhere in between, firm to hard kind of a situation, you may be dealing with, and it's only in the muscles, the bone is not involved, and you may be dealing with something like a soft tissue sarcoma. So these are the things that you need to be looking for. Obviously, we follow the same protocol of inspection, palpation, examination of the range of movement, and we go out to the measurements, look for the girth, look for the liminal discrepancy, the angular deformity, and also make a note of the gait that the patient is having. So once you have finished these particular classical examination points, what you should be, you should have certain things in your mind. You should have certain idea of that particular diagnosis in your mind at this particular level. You should be thinking whether it's a primary bony neoplasm or it's a secondary bony neoplasm, whether it's a bony origin lesion or whether it's a soft tissue origin lesion, whether it looks benign, whether its behavior is benign considering the duration of presentation, or whether it's been very aggressive in its clinical behavior. Obviously, what's been the site of affection and what's the functional disability the patient has got. So all this has to come in your diagnosis. So these are the things that will cover in your diagnosis when you're speaking to the examiner. So obviously the examiner is going to ask you, so doctor, what do you want to do next? And the first and most important answer that you need to give to the examiner is, don't think of anything else but an X-ray. Okay, so a simple plain radiograph of the affected area will be the first and most important investigation in these particular patients. Very early cases, you need a very high index of suspicion. You would probably pick up few lesions only on the MRI scan. The radiograph is going to give you different types of lesions. It could be a lytic lesion, it could be a sclerotic lesion, it could be a mixed variant, a lytic sclerotic. You have to note whether it is periarticular in the metadiaphyseal area or it is in the diaphysis. So there are certain tumors which are more common in the metadiaphyseal areas, certain tumors which are more common in the diaphyseal areas. We know that. Certain Ewing sarcomas said that it's more common in diaphysis, but about 10% of osteosarcomas can also affect the diaphyseal region. So doesn't mean that it's diaphysis, so it has to be Ewing's. Well, osteosarcomas can also affect the diaphyseal area. So keep that in mind. Think about the various clues that a radiograph is going to give you. So think about what's the relation of that particular mass with the adjoining joint. What's the soft tissue extent? How big is the extraosseous soft tissue component? What is the kind of periosteal reaction? Periosteal reaction and a matrix is going to give you a lot of clues about what type of tumor you're going to deal with on that particular X-ray. So onion peeling, we know that it's going to be probably an Ewing sarcoma. Codman's triangle and sunburst appearance or a sunray spicule appearance, we know that we are probably dealing with an osteogenic sarcoma. And there's something known as a zone of transition. What does a zone of transition mean? It's the difference between the affected area and the unaffected area in the bone. So if the zone of transition is narrow, it means that you're probably dealing with a benign etiology. If the zone of transition is broad, it means that it's a malignant tumor. And since we are going to deal with malignancy, the next thing that we need to see is what is the lesion made up of? Means what is the matrix of the lesion. So the matrix, if it's calcification, on the left hand side you can see these arcs and rings and popcorn like calcific masses. So it means that probably you are dealing with a chondroid neoplasm over there, but it's a very soft bone forming, osteoid forming kind of a lesion in the tibia as you see over there. It means that you're probably dealing with a bone forming lesion which is likely to be an osteogenic sarcoma. Okay, and always say that it is most likely to be an osteosarcoma or a chondrosarcoma. Don't blurt the pathological diagnosis on the radiology. Give it to the examiner. Another important X-ray that you need to talk about is going to be the X-ray chest. It will tell you whether the patient has got any obvious cannonball secondaries in the chest X-ray or not. If you don't see any cannonball secondaries, the next investigation that you need to tell is a CT scan of the chest. It's going to be usually a non-contrast enhanced thin slice CT scan, because less than 2 centimeter size secondaries are not seen on a plain X-ray. For these to be picked up, you need to do a CT chest. Okay, and this is important because your further management is going to be decided whether the patient has got metastasis or has not got metastasis. And sometimes you need to think of getting a CT scan done for the involved area also for your surgical planning. But the most important investigation currently in a tumor case is an MRI scan. And what are the different advantages of getting an MRI scan done? Yes, so basically it gives a very good idea about the soft tissue extent of the mass. Next. Okay, if you have to look at a slide and then say, what does it tell you? Intramedullary extent of the tumor. You know, the periosteal reaction stops at a certain level, but if you see the MRI scan, the intramedullary extent is much higher up. So MRI is much better to give you the exact extent of the, and these are all T1 weighted images. Okay, so T1 weighted images are the ones that you look at. So the intramedullary extent is told by the MRI. What else does it tell you? Skip lesions. Yes, correct. What else does the MRI tell you? Intra-articular involvement. Okay, so all these things they have to be noted on the MRI scan. What other information does the MRI give? Absolutely, whether the neurovascular bundle is on the surface of the tumor or it is inside the surface of the inside the mass of the tumor. So here you can see that it's a big osteogenic sarcoma in the discipline of the femur, and the neurovascular bundle is completely engulfed inside that particular mass. So that gives you an idea about what's going to be the probable management of that particular patient. Certain other advantages is that you know what's going to be the chemo, or what has been the chemo response in that particular patient, how well the patient has responded to chemotherapy. So in tubular heaving sarcoma on the top slide before chemotherapy, and on the slide beneath is after chemotherapy, you can see that it's responded extremely well to chemo, and you know that it's much easier to operate on a tumor which is much smaller in size. Sometimes the MRI is also used to differentiate whether a tumor is benign or malignant, and it's known as a dynamic contrast enhanced MRI. And it's something that you just need to know about. You may not be asked about it in much of the details. And obviously, MRI is extensively relied upon to plan our surgeries, to determine our margins, and to tell us how our surgery is going to progress. After you have talked about the MRI scan, this was a local staging. You can say that this was a local staging investigation which tells us about the extent of the disease in that particular affected bone. What about the rest of the body? So one good investigation in an osteosarcoma case is a bone scan. The bone scan is going to give you an idea about whether the patient has got any other bony lesions or not. It's not going to tell you about the visceral metastasis. But there's a little bit of a pitfall over here. Bone scan is very, very sensitive, but the specificity is very low. So you can get a false uptake if the patient has had a trauma, or if the patient has had some kind of an infection in that particular area. So be aware of these particular pitfalls when you are reading the reports or seeing the slides. One of the newer investigative modalities is a PET scan. Anyone knows what a PET scan is? Yeah, of course, it's a positron emission tomography. But what is used? What isotope is used in a PET scan? Yeah, it's known as the 18-deoxyglucose, and the uptake in that particular affected area is measured. What the actual machine does is it's a combination of a anatomical imaging like a CT scan with a functional imaging like the isotope uptake. So basically these are two scans done by the same machine or in the same gantry, and then the software puts the two images together and gives you an image of the anatomy along with the physiological activity that's going on over there. Okay. So what after the radiological investigation? You have got everything done. So you have a tumor osteosarcoma case. You have done everything. You know that the patient does not have any metastasis in the chest or anywhere else in the body under bone scan. So what are you going to do next? Start chemotherapy? Biopsy. Why biopsy? Okay. So once your radiological investigations are done, before you go on to the biopsy, you have to comment upon what's the local extent of the tumor, what's the distant staging, so whether the patient has metastasis or not, and then you have to talk also about the details about the adjoining joint, the host bone, and whether there are or there are not any skip lesions in the intramedullary area. So these are the things that you need to be commenting upon. Okay? And remember that biopsy is the final diagnostic procedure in the entire workup. It is not to be done as, and it is not to be said as the first investigation of choice. Okay, so it comes as the last investigative modality, and it is always a must in all benign aggressive neoplasms and all overtly malignant tumors on X-ray. When do you do the biopsy? After all the imaging is done, because sometimes a tissue reaction to an open biopsy can alter the appearance on the imaging. Where do you do the biopsy from? That's also best answered by the MRI scan. So area where you have a very good uptake of gadolinium is the most active area in the tumor, and that is what you are supposed to target when you are doing the biopsy. Ideally to be done by the person who is going to treat the patient definitively and in the institute where he is going to be treated. Just remember that there can be problems with biopsies also. There can be complications, and we land up in doing amputations for badly done biopsies. So you have to know what is the correct biopsy. How to do a correct biopsy? Quickly, 1, 2, 3, 4, anyone knows?
Right.
Principles of biopsy? One compartment, longitudinal incision in the extremity.
The biopsy scar should be according to the definitive surgery.
Yes, it should be in the line of incision of the final surgery. Then?
No tape. No tape.
So avoid wide hatch marks, I would say. Okay, so no big sutures, because you have to excise that particular surgical scar. So if you have to mention it in short to the examiner, say that I'll take the shortest route to the tumor. So from the skin, shortest route to the tumor, avoid the extensor mechanism. So avoid the anterior compartment in the distal femur and avoid the patellar tendon in a proximal tibia. Okay, you should violate only one compartment. Don't violate multiple compartments. Okay, you should be as away from the neurovascular bundle as possible, and you should be as away from the joint as possible. So even if you say these 4 or 5 things, it is good enough. Longitudinal incision, yes, that's a good point. Place it on the incision of final biopsy scar, that's also a valid point. And if you say at least, the examiner is going to be pretty pleased with you. There could be 2 ways of doing the biopsy. One is a needle biopsy, one is an open biopsy. Of course, open biopsy gives you more tissue, so it's much easier to do a lot of other investigations on that. And even an average pathologist who's not so experienced can give you a correct diagnosis. But you can see that the scar that is excised at the time of final surgery is much bigger in size. As versus if you compare this with a needle biopsy, the scar that is excised at the time of final surgery is very small. Okay, but the issue is that you need an experienced pathologist to comment on this particular tissue. It's a very small tissue. Advantages: can be done under local anesthesia, can be an OPD basis procedure, less chances of having a fracture, less chances of getting an infection after the procedure. Multiple advantages. Can get ghost from the depth of tumor. So these are the advantages that you should be able to tell the examiner. Now the needle biopsy can also be done either blind or with the help of a CT scan. It is called as a CT guided genital biopsy. You just take help of the CT scan to localize the tumor and do the biopsy. The problems: it may not give you good tissue. You may not be able to make a diagnosis if you don't have an expert pathologist. And you may go wrong in sampling, so there could be sampling errors, so you will not get a right grade of tumor. Sometimes you may resort to doing an open biopsy after having done a needle biopsy. Typically, when you don't have a diagnosis, when your radiological diagnosis doesn't match your pathologist's report, and if your needle biopsy has come out to be inconclusive or negative. So you may still have to resort to an open biopsy, but we nowadays tend to avoid these situations and rely only on getting a needle biopsy done. So these are the areas, or these are the situations where we would still do an open biopsy. So everyone is clear about these particular things? Okay, so this was about the flow chart of how we are going to approach and manage primary bone neoplasm extremity case. Okay, any questions till now? So the workup is very clear.
Biopsy should be at the junctional and the tumor.
Yeah, basically the explanation to this is it says that it should be at the end of that particular lesion, because that's the maximally growing area. So you have got a great chance of having a viable tissue over there. The explanation to that is that even since the sarcomas go centrifugally, they are growing from inside to the outside, they are pushing away the muscles. So even if you target the periphery, that will also give you viable tissue. The central area will be necrotic. The idea is to avoid the necrotic area so that you have viable tissue for the pathologist to make a diagnosis. And that particular viable area will be very well marked out on the MRI, especially if you have done a gadolinium enhanced MRI scan. Okay, so that's the way you decide where to target the biopsy. Okay.
How reliably can you predict the aggressiveness? Can biopsy be a aid to?
Yes, biopsy tells us about the grade of the tumor. What grade? Whether it is a well-differentiated tumor, whether it is a moderately differentiated tumor, or whether the cells are looking highly undifferentiated or anaplastic. So that's the way you can talk about the grade of the tumor. Typically, when we talk of Ewing sarcomas and osteosarcomas, they are usually high-grade lesions, the conventional ones. If you are talking of chondrosarcoma, there are either grade 1, grade 2, grade 3, and the prognosis is different as per the grade. Okay, so I'll be spending another 5 minutes. Actually, we are a little out of, we are exceeding the time a bit, but I'd like to spend the next 3-4 minutes on giving you an idea about the current concept of limb salvage. So what used to happen in the past, before the 1980s and 1990s, was that we used to have patients and they used to die even after treatment. The treatment usually used to be an amputation, and they used to die because of development of metastasis. What happened later on after the 1990s, as the chemotherapy was available, is that now we give them neoadjuvant chemotherapy, that is chemotherapy before the surgery. We do a lot of limb salvage surgeries. Almost 90 to 95% of our cases are treated by limb salvage, and we get a possible cure in almost about 50 to 60% of our patients. So as of now, even with the non-methotrexate based chemotherapy, we are able to get a 60% or 50% cure rate in our patient. And limb salvage is undergoing a lot of change nowadays. We know that amputation is the most merciful of surgeries when it is the only resort. A patient like this, there's no resort. The patient is going to be very happy if you do an amputation for this kind of a situation. But we say that it's one of the meanest surgeries when better alternatives are available. What do you think? What is the best between the two, an amputation and a limb salvage? Which is better? From a long-term point of view, from a prognostic point of view, or a risk point of view? Which is better? Limb salvage, are you risking a local recurrence, or are you risking the disease spreading to the other areas of the body? What is your take? Anyone can quote any literature? Okay, so if the examiner asks you this, so you have a few papers, you can tell that when an amputation is compared with a limb salvage, when an adequately done surgery by a properly done surgeon and using appropriate chemotherapy, there is no difference in the overall survival and the local recurrence rate. There is no statistically significant difference in these two rates in both the situations, in patients treated with an amputation and in patients treated with a limb salvage. And that's the reason why I said that most of our patients now get treated with limb salvage. Obviously, we treat our patients nowadays, especially in case of Ewing's and osteo in the form of neoadjuvant chemotherapy. There are multiple advantages: healing of pathological fractures, taking care of satellite nodules, taking care of micro metastasis in the body, resolution of the soft tissue component, better dissection, reduction of vascularity. So these are the multiple reasons why we use neoadjuvant chemotherapy. You can assess the chemotherapy response after surgery. In the past, it used to give us some time for fabricating the customized endoprosthesis and stuff like that. So, obviously the chemotherapy makes a lot of a difference as far as the surgery is concerned. Once we do the surgery, the pathologist can sort of dissect the entire specimen, make various blocks, and assess whether the tumor is showing 100% necrosis or 90% necrosis or less than 90% necrosis, and we can sort of prognosticate how the patient is going to do. And I say that the surgery has to be done in a proper way. So the surgery has to be done with a wide margin. So what exactly is a wide margin? So if the examiner asks you, how are you going to resect this particular tumor, say in a distal femur, what are you going to say? You are going to say that it has to be a wide margin. And the concept of this particular margins has been given to us by William Hennig. And he's talked about 4 things. He's talked about an intralesional excision, a marginal excision, a wide excision, and a radical excision. So you need to know what these 4 things mean. Intralesional, you remove the tumor piecemeal, not done in osteosarcoma and Ewing's and chondrosarcoma. Marginal means you have taken out the tumor through the reactive zone. That is also not done in case of sarcomas in the extremity. Wide, yes, that's a choice where you have taken out a bit of extra bone and an extra muscle as a layer on that particular sarcoma. And radical means that you have removed the entire compartment, something like a high-level amputation, which is again nowadays not done for sarcoma. So this particular concept you need to know. You need to know the concept of Kawaguchi, which was published in the CRR in 2004, which he talks about curative margins, and where he has emphasized that the quantity of margin is not important, the quality of margin is. So what is the margin nowadays? For us, it is 3 centimeters in the bone. We leave one normal layer of muscle on the soft tissue component of the tumor when we take the tumors out, and we tend to keep barriers like the periosteum, fascia, perineurium, vascular sheath, and that is quantitatively equivalent to 1.5–2 centimeters margin, even if it is a few millimeters in thickness. So this particular concept has changed our understanding of limb salvage surgery. It is always a multimodality treatment: chemo, radiation, surgery used in the right combination, in the right sequence, and the right time. It's always a multidisciplinary team that decides how to manage the patient. So I'm not the one person alone who's going to decide the treatment. All the others in the multidisciplinary team decide how the patient is to be treated. What are the patients you choose for limb salvage surgery? Patient decision is made on the basis whether the patient has got metastasis or not, whether the leg is salvageable or not, or the extremity is salvageable or not, and in countries like ours, what's the socio-economic status of the patient, whether he's going to really afford that kind of surgery or not. And you do a limb salvage surgery only if the patient is going to take adequate chemotherapy, the function in the salvage extremity is going to be good, and you are going to be able to achieve wide margin in that particular patient. So you need to achieve a good balance between saving function and controlling the disease, but never compromise disease control to save function in that particular extremity. There are cases like these where you can try to be godly, but remember that you are not gods. You cannot do limb salvage in these particular situations, and you have to be real. We have to be realistic in setting our goals. What are the absolute contraindications for limb salvage surgery? Only two. One is encasement of a major motor nerve and inadequate muscles which are left behind after surgical excision. So remember, these are the only absolute contraindications. The other contraindications are mostly relative: infection, pathological fracture, involvement of vessels. This can be dealt by various surgical techniques. You can reconstruct these particular defects. So you see a defect which is about 15 to 20 centimeters in size around the knee, and the reconstruction is expected to be stable, it is expected to be mobile and durable, to be giving a good function to that particular patient. What are the options? Customized prosthesis or modular prosthesis nowadays is the most popular option. Doing an arthrodesis could be another option. Rotation plasty in patients, especially in kids less than 8 years of age. You can do an extracorporeal radiotherapy and reimplantation, or autoclaving and reimplantation. Nowadays, a few centers are also trying partialization and reimplantation. You could do osteoarticular allografts for reconstructing the defects. Osteoarticular allografts are not available in India, so that's not an option that we are having currently. You could just do an allograft prosthesis composite, so that can also be done. And obviously, you need to take into consideration various factors: the age of the patient, size, the demands of the patient, and the expertise that you have got in deciding what you're going to offer to this particular patient. So nowadays, most of our patients end up having a limb salvage surgery even after they have had a diagnosis of an osteosarcoma or any sarcoma in the extremity. Alright, so that was a brief overview. I'm sorry I sort of overshot the time by 7 to 8 minutes. And for the detailed part, you can visit the website of Journal of Bone and Soft Tissue Tumors. That's www.jbstjournal.com. We have a separate section for postgraduate students in that, which is labeled as a student's corner, and there are various short notes that you can resort to. So this particular corner has been dedicated especially for exam-going students, and you can just refer to it. And the other issues of the journals talk about the workup, the advantages, the role of PET scan, and stuff like that. So you can refer to this particular, the previously printed issues for the rest of the information, and it's available online free of cost to everyone. Thank you very much. We had 10 minutes left for discussion, but I have utilized those. So if anyone has some quick questions, I can take that in maybe next 2 3 minutes.
In case it's a management tumor, the muscle layer is not affected. So what about doing a biopsy in that? Because I just read somewhere then we actually risk of exposing the muscles to the